Hi students, today we're going to discuss Ebola and specifically how stigma and miscommunication and misinformation around Ebola can stymie global health efforts and create true challenges for sufferers and survivors. Just to briefly review a little bit of what you learned in reading about Ebola in David Quammen's text. It's a zoonotic disease that originates in bats as the reservoir species and that may be amplified by great apes, notably gorillas, also chimpanzees. Occasionally some other organisms, but most frequently with great apes as the amplifier if an amplifier is present. It is frequently fatal, and the case fatality rate for Ebola has varied between different strains of disease and different contexts of the outbreak. But generally, it's anywhere between a 40% to 75% case fatality rate. And it's characterized by a high fever, diarrhea, vomiting, and respiratory distress in terms of the symptoms of the disease. However, the symptom it's most commonly associated with is hemorrhage. This is due to some sensational writing in a book called The Hot Zone that came out when I myself was in high school by Richard Preston. It really stimulated a lot of excitement and interest in vaccinology, immunology, virology, but didn't give at all a clear and accurate description of the actual manifestations of Ebola. While it has been considered a hemorrhagic fever, hemorrhage is not found in all cases. It's actually not even found in most cases of Ebola. And it's not even the symptom that's most consistent with a poor prognosis for the patient. The symptom that's actually most associated with fatality in Ebola patients is actually hiccuping. And so when a care provider in an Ebola outbreak has a patient who cannot stop hiccuping, that's generally the really sad sign that it's going to be a fatal case in most circumstances. The incubation period for Ebola is about 2 to 21 days, which means that during the West African Ebola crisis, which we'll discuss shortly, there was generally a 21-day waiting period between individuals who had known exposures to the disease could tell whether they had been actually infected in that encounter. And that 21 days founded the basis for what the WHO used as its indication that an area was Ebola-free, which was that there had to be no more new cases reported in twice the maximum incubation period of 42 days. So after a 42-day period without any new cases, different areas during that crisis could be designated as Ebola-free. So there have been a number of Ebola outbreaks. Prior to 2014, they had all essentially been in Central Africa, in forested rural communities. There was one case of laboratory transmission that was traced to an ape in Cote d'Ivoire in 1994. It was actually a different strain that's only been seen once in humans, but other than that one kind of lab-transmitted case, all of the cases prior to 2014 had been in Central Africa among rural communities, the majority of which have been in the Democratic Republic of the Congo, which is where Ebola was first recognized. It also was recognized early on in Sudan in a separate outbreak around the same time, but just slightly after it came to the attention of authorities in 1976. However, 2014 changed all of that, and that's where we saw the largest Ebola outbreak that the world has thus far still ever seen, that was centered around 3 countries in Western Africa: Liberia, Sierra Leone, and Guinea. It also involved some spread in a limited way to a number of other countries in Africa and beyond. So just for some context, here are some Ebola outbreaks of the past. I mentioned those two in 1976, one in the DRC, which was then called Zaire, and the other in Sudan. The outbreak in DRC in that year had 318 infections. The outbreak in Sudan had 284 infections. And prior to what's happened more recently, those were considered very large Ebola outbreaks. Often the outbreaks were smaller in number. And so these that are just listed on this chart are some of the biggest ones that had preceded that time. However, the crisis in 2014 through 2016 eclipsed all of that, with a total of 28,646 cases around the world and 11,323 deaths around the world. Overwhelmingly, while there was some limited, generally travel-associated spread with very limited continued person-to-person infection within the countries that were initially impacted by a travel-associated case, the toll of the crisis was felt overwhelmingly in those three countries, Guinea, Liberia, and Sierra Leone, with just marginal numbers of cases and deaths in other locations. And so prior to the past few months, the West African Ebola crisis was really looked at in global health as our most recent big critical experience of a emerging infectious disease spreading significantly in an area where it hadn't been seen before, and sparking lots of concerns about travel, about response, about the strengths of health systems. It is still, this particular crisis is still all of those things, but it has, of course, been in some ways eclipsed by our current experience, which is really reshaping a lot of how we can discuss pandemics with each other and with our students. We as the global health community have been waiting for what many call the next big one for a number of years. And during the West African Ebola crisis, there was some conversation within the community about whether this was the next big one, and the decision overwhelmingly was that it wasn't, but it was still very major, whereas we are in fact living through what many would consider to be the next big one now. So there were just a few contributions by some of the authors we've been working with in this course that I wanted to make sure to share with you today. This is actually from the book Pandemic that many of you were able to read over break. And in case you didn't have a chance to finish reading the book, I still thought that this one brief piece was important enough that I wanted to bring it into lecture today. So Shaw writes, during the 2014 Ebola epidemic in West Africa, healthcare workers attempting to safely remove still contagious corpses were chased, lied to, and assaulted. A mob attacked a team of 8 healthcare workers, politicians, and journalists as they attempted to distribute information about Ebola. 2 days later, their corpses, including 3 with slit throats, were found in the septic tank of the village's primary school. People in Guinea, Liberia, and Sierra Leone had suffered more than 2 decades of human rights violations and atrocities at the hands of the military before Ebola arrived, eroding public trust in authority figures. The fact that healthcare workers imbued with official authority were mostly foreigners probably didn't help inspire confidence among the locals either. And then Brown and Flosser, in the introduction that's included in the book to some of the readings that we found alternate versions of online that we shared with you now that we've switched to digital instruction for the class, emphasized that in the United States, fear and rumors ran wild during the Ebola epidemic, despite the fact that we only had a handful of cases of the disease. Politicians rushed to put quarantines into place, even as most public health professionals pointed out that they would do no good in this context and might discourage public health professionals from going to West Africa to help with the outbreak. Nightmare scenarios that the Ebola virus might go airborne were repeated on the media. Anti-vaccine sites on the internet spread fake news that Ebola was being spread deliberately just to create a market for a vaccine, despite the fact that a life-saving vaccine didn't exist yet. However, the primary reasons for the spread of Ebola was the weakness of health systems in West Africa. That went under-addressed and under-recognized in the US media and popular discourse. Instead, the US media focused breathlessly on traditional cultural practices and supposedly uncooperative behavior of the people in those three most affected countries. It's important for us to remember as we're learning about global health that this is a form of ethnocentric miscommunication, and it blames the victims of a disease rather than addresses the root causes of that outbreak and working towards a solution to address it. One way that this was manifested in the US media and social media at the time was through this quite prominent tweet, which was screenshot and saved many, many times over beyond what you just see here as retweets and likes on the tweet itself, by an individual who at that point in time was known as a prominent businessman and reality television star, that emphatically argued the US cannot allow Ebola, all caps, infected people back. People that go to faraway places to help out are great, but must suffer the consequences. And with this tweet, this individual who has since risen to, as you know, quite a place of prominence in the United States, was making the argument that healthcare professionals who went on humanitarian missions to treat patients of Ebola in West Africa were taking a risk in doing so that should disqualify them from free reentry, or rather, I guess I say unrestricted reentry into the United States, and instead that there were these consequences that he speaks of in the tweet that they must suffer as a result of their humanitarian efforts to fight a potential global pandemic. This type of sentiment was not only held by this individual. It was frequently repeated by certain voices in the social media and the popular media, and it created a number of challenges for those healthcare workers who did go on these trips, including some personal friends and colleagues of mine, and the response that they were treated with after they came home. One in particular is this nurse named Casey Hickox, and I'll put an optional reading about her on the Blackboard for you and share it in the Slack. But she was a nurse who traveled to treat Ebola patients in West Africa, and upon return to the United States after standing in line, following a long flight and feeling flustered, registered a slightly elevated temperature. She never tested positive for Ebola because she never had Ebola, and her slightly elevated temperature was resolved just an hour or two after this encounter. But the governors of New York and New Jersey, she had flown back into Newark Airport, insisted on a dramatic inpatient quarantine protocol for her that was not consistent with public health understandings of best practices for people who are asymptomatic from Ebola. Because unlike our current crisis with COVID-19, there has been no indication of any asymptomatic transmission of Ebola. Ebola sufferers are not symptomatic until, or rather are not infectious until they develop symptoms of the disease. So the standard protocol for returning health workers that had treated West African Ebola crisis victims was to monitor their temperatures and engage in daily regular life. If they developed any symptoms of Ebola, to then restrict themselves, go for testing, be in consultation with local health professionals, and so forth. And so Casey Hickox recognized at the time that complying with this unfounded demand that came from a place of fear and political jockeying rather than any evidence-based recommendations would undermine global health efforts and would make it more difficult for future and current public health professionals to go on these humanitarian efforts in times of crisis. And so she fought the quarantine order and did return to Maine, where she was a resident, and continued to monitor herself through the entirety of that 21-day period that I talked about. to see if she developed any symptoms of Ebola, and she never did. A lot of people excoriated her in the media, thought that she was being irresponsible, thought that she was being selfish, thought that she was being self-centered. But people in the public health community often look at her as a public health hero, for emphasizing the importance of basing policy on evidence and not fear, and on cementing really the opportunity for other volunteers in the health professions to go and to help and treat people in times of crisis like this. So one thing I want for you to remember as you read through the 2 readings for class this week, if you haven't already, and as you are engaging in your discussion groups with your teaching fellows, are that stigma and misinformation are critical threats to global health, but that solid health communication can help to combat that. I think it's absolutely urgent that we not overlook the importance of this in times of crisis, because this, getting out solid health communication that's driven by evidence, not fear, is also urgent. Thank you very much, and I will look forward to talking with you more over the Slack.